Hi, welcome to the Doc Dave Show. Once again, we meet on this show. As you know, this show is about health promotion. It's about talking about the common medical problems that affect us in real life. The show is not about prescribing what you should do, but rather it's about information sharing, basically. Ultimately, you need to share that information with your own health practitioner or healthcare provider if you've got any issues. But here, just share the information, common conditions that affect us. And I'm so pleased that in the studio today, we are going to talk about what's called ischemic heart disease. And also, you see that it's called as coronary artery disease. It's pretty much the same thing, okay? So there is so much death in the world, and it remains the #1 killer in the whole world. So that's why it's important that we know some of the risk factors. Maybe we can change things here and there. Okay, so we can change lifestyles, we can promote people to live healthily. So in the studio today, I'm so pleased I got Dr. Shaun Lattouf. Dr. Shaun Lattouf is a well-known cardiologist, interventional cardiologist. He trained in South Africa. He did his interventional cardiology in New York, in the United States of America. He is so passionate about ischemic heart disease, and he has agreed to come to the studio to share what he knows from his clinical experience. So, ladies and gentlemen, welcome Dr. Shaun Lattouf to the show. I'm so pleased you have made it to the show, and we really appreciate taking the time.
Oh no, David, it's a pleasure coming here, having a chat to you.
That's very good. Yeah, and you're looking well, and the rest of the family, they are all good?
Excellent.
Fantastic, fantastic. Now, you're a well-known cardiologist, very much well-known in the town here. And from my talking with you in the background, you are so passionate about ischemic heart disease, what we also call coronary artery disease, because it's the #1 killer in the whole world. And according to the statistics I was checking, there's 56 million deaths in 2017 across the world. It is #1 killer. And going by country, again, it's topping in Australia. Apart from England, it's #2. #1 is dementia and Alzheimer's. But most of the countries, ischemic heart disease remains the #1. What's your take from your clinical experience?
Well, as you said, it is the leading cause of death in the Western world. And as the world becomes increasingly global and increasingly a global village, then it's becoming a bigger problem in the so-called undeveloped countries. The biggest issue with ischemic heart disease is the fact that it is often diagnosed too late, and that there are a multitude of cardiac risk factors that are not dealt with early. And so what we really want to do with ischemic heart disease is A, we want to prevent it, B, we want to recognize it early, and C, if somebody presents with a manifestation of ischemic heart disease, we want to treat it quickly and effectively. Because one of the problems is that in about 50% of people, their first presentation with coronary artery disease will in fact be as a sudden cardiac death.
That's right.
And so what we need to be able to do is to have adequate prevention of the disease. We need to have adequate screening programs to recognize disease that is not yet symptomatic, and then we need to treat the symptomatic disease effectively.
Yes, then we can prevent fatalities if we
Correct.
can. That's right. So now talking about the risk factors you just brought in, and what would you say is the #1 risk factor for this?
Well, I think what we have to do first is we need to look at risk factors and say that risk factors are either modifiable or non-modifiable.
That's right.
So if you have something that's non-modifiable, for example, a dreadful family history, well, there's not a lot that you can do about your family history.
That's right.
But if you have something that's modifiable and you choose to ignore it, then quite simply you're being stupid.
That's right.
So the risk factors, the major risk factor is that of smoking. The other major risk factors would be those of diabetes, elevated cholesterol, and high blood pressure.
Yes.
And then there's other secondary risk factors that are a little less important, but obviously important. So somebody who already has vascular disease in another territory is at risk of having heart artery disease, because essentially the body is a multi-system organism, and so if you've got narrowed arteries in your legs or in your neck, you're going to have narrowed heart arteries as well.
That's right.
Other risk factors would be kidney dysfunction, and stress as well also plays a role in developing coronary artery disease.
Oh, stress. Oh, wow. We shouldn't be stressed.
Yeah. Well, I don't think I'm particularly distressed. Yeah.
That's right. That's okay. Now we are so looking up at the risk factor in more detail.
Yep.
You talked about smoking. What exactly happens? How does it damage the coronary arteries?
Okay. Well, essentially, the artery can be perceived as a tube. And that tube consists of 3 layers, and there's an inner layer, there's a middle layer, and there's an outer layer.
That's right.
And the development of plaque happens between the inner and the middle layer. So the inner layer we call the intima, and the middle layer we call the media, but then in the layer between the two, that's where plaque forms.
Yes.
And what smoking essentially does is it continually damages the superficial layer and then causes an inflammatory reaction. And that inflammatory reaction is associated with the deposition of certain inflammatory cells just underneath the surface, and that then promotes the development of plaque. And once you start getting plaque, unless you can stabilize plaque, or unless you can cause plaque to regress, then it is inevitably going to get bigger and bigger.
That's right.
And so with smoking, if you've had an exposure to smoking, you're putting yourself at risk of getting plaque. But if you stop smoking, you stop further plaque forming in some instances, but you also take away some of the effects of smoking on the constituents of the blood carrying system itself, like effects on platelets and red cells. So if you smoke, you have much higher density of red cells, so your blood flow is a bit more sluggish. Smoking has an effect on platelets, which are the things that promote clotting within the blood. Smoking has an effect on the reactivity of the wall and actually causes spasm of the wall. So all of those things can actually cause a heart attack. So what you have is a tube, and within the tube there's an area of plaque, but within the tube there's blood flow, and you want to have an effect on all of those things in order to stop the cycle that promotes heart attack.
Right, so it's very important that we stop smoking, definitely.
Oh, absolutely.
And
it's not negotiable.
As healthcare providers, we need to encourage smoking cessation, and there's lots of strategies, for somebody to come off smoking or to quit smoking.
Correct.
Lots of programs they are in support of that. We know that it's so difficult to come off smoking. It's a dreadful habit, especially if you're smoking heavily and for so many years. But it's not inevitable. It can still be done, isn't it?
Correct.
Yeah, that's
Correct.
right. And the second thing, what you say, lipid profiles? Or?
Yeah, I mean, certainly cholesterol. So smoking is a modifiable risk factor. And then we've got, if you like, the metabolic risk factors, which are essentially those of elevated cholesterol, diabetes, and to a lesser extent, hypertension or high blood pressure. So cholesterol is a major risk factor.
Yes.
And some cholesterol is genetic. So that's how you're born, and some cholesterol is a lifestyle issue which is mediated by diet or by lack of physical activity.
That's right.
And in essence, if your cholesterol is sufficiently high and you have other cardiac risk factors, then you need to do non-pharmacological treatments such as diet and exercise, but you also need pharmacological treatment, and that particular group of drugs we call the statins.
Yes.
And what the statins do is that they biochemically lower people's blood cholesterol, but biologically they have an effect on the makeup of the plaque or the obstruction within the heart artery. And by changing the makeup and the inflammatory nature and the lipid or fat nature of that plaque, they then reduce events.
Yes.
So anybody who has heart artery disease, statin treatment is pretty much mandatory, and that's not negotiable. And there's very, very elegant drug trials that have been performed now for the past 25 plus years, which are what we call double-blinded trials. In other words, neither the doctor nor the patient knows what they're getting.
That's right.
And they're controlled against placebo, in other words, a non-active drug. And all of those trials universally show that lowering cholesterol lowers cardiac events by 30 to 50%.
Wow, that's very good. That's very good. But there's been some controversy on the media regarding statins, and I've seen some of my patients coming to me saying, "I need to come off this drug. I've seen this negative effect of it. I don't want this dementia and all that stuff."
Yeah. Unfortunately, the media doesn't necessarily understand the biological processes, and unfortunately, everybody knows somebody who has had some muscle aches and pains on the statin, and therefore they assume that it is going to be a problem for themselves.
Yes.
I mean, the facts of the matter are, firstly, that the muscle aches and pains that you get on statins are not as common as people believe them to be, and in fact occur less than 10% of the time.
That's right.
And they are completely reversible.
Yeah, you're right. Yeah.
And the second fact of the matter is that when people are told that they're taking a statin, but they're actually on a placebo, they have a higher incidence of perceived muscle aches and pains than when they're actually taking a statin but are told that they're on a placebo. And there was a very elegant British trial that crossed over patients in a blinded fashion between being on the active drug or the statin, being on a placebo, and crossing them over back and forth, but deceiving the patients as to which drug they were on, and showed that if they believed that they were on the drug, they had more aches and pains than when they weren't on the drug.
That's right. That's very good. Yeah. Now, I mean, breaking down the cholesterol into categories. I mean, you've got the triglycerides,
right,
and we've got the LDL, the high density, low density lipid. Of those on the triglycerides, the LDL, the risk is the same?
No. So if we're going to look simplistically at lipids, which lipids is just a fancy technical term for fats, we'll talk about lipids can be divided simply into cholesterol and triglycerides. Triglycerides are much less important as an independent risk factor for heart artery disease, but triglycerides are often elevated in people who have diabetes. And then if you control the diabetes, you control the triglycerides. But there's always a tendency to want to treat the triglycerides, but you're getting your most powerful effect by actually dealing with the cholesterol. Right. So the cholesterol can then be divided into three: your total cholesterol, your HDL, which stands for high density lipoprotein cholesterol, and your LDL, which is low density, which is in fact the bad cholesterol.
That's right. Yeah.
And what you want to do is you want to have as high an HDL cholesterol as possible and as low an LDL cholesterol as what you can get.
Yes.
And HDL, you can raise that with exercise. And we have tried to elevate HDL with various drug trials, but those drug trials have been singularly underwhelming or unsuccessful.
Right.
LDL you can lower with exercise, but LDL we can lower with the statin group of drugs.
That's right. Okay, that's good.
And that's what we really want to do. We want to lower LDL, because by lowering LDL, we've got less fatty cells that then get into that plaque. And the lower you get the LDL, the more stable you make the plaque. And we, in fact, have very elegant studies where we look from inside the artery at the volume of the plaque with an ultrasound device and show that people, before they get the statin, have a certain plaque volume, let's say 50%. So 50% of the artery is taken up by plaque. And when you give them the statin and you lower the LDL to a target level, the plaque shrinks, and it shrinks to, let's say, 20 or 30% plaque volume. And it's also a much more stable plaque, and that translates to an event reduction.
Yeah, that's very good. That's very good. Now, we said smoking, number one, and we got the cholesterol, number two.
Yes.
Obviously, we need diabetes to be controlled.
Diabetes absolutely needs to be controlled.
It's very, very, very important that we take the medications, it's ordered, and we do a physical therapy, like you said. Losing weight is a key factor.
Correct.
Keep immobile. That's all imperative.
Absolutely.
And we can't change the genetics. If it runs in the family, coronary artery disease runs in the family, we can't take the genetics. We can only change the risk factors.
Correct, and that's why we've made reference to modifiable and non-modifiable.
That's right. Yeah, that's okay. Right. So you get a phone call from the emergency physicians. Somebody's coming young, 45 or 46. Chest pain, they confirm heart attack on blood test, on ECG, and now refer to you. Where do you take it from there?
All right, well, I mean, the presentation with heart artery disease can occur on a spectrum. So there's a group of patients on that spectrum that have absolutely no symptoms whatsoever. And then on the other end of the spectrum, you have a group of patients that have heart artery disease and present with sudden cardiac death. So they present with a heart attack, and that's the sort of patient who knows nothing about their heart arteries, and they have a heart attack and they get a malignant arrhythmia. The heart goes into fibrillation as a consequence of the heart attack, and they drop down dead. So that's the opposite end of the spectrum.
Right.
In between that, you have patients who will present with a so-called heart attack, or you'll have patients who will present with what we call unstable angina, which is essentially a precursor to a heart attack or a warning symptom, or you can have patients who present with so-called stable angina. And in order to manage the patient, it depends where they are on that spectrum of being stable to unstable. And the more unstable they are, the more urgent it is to deal with them. So if the person in the emergency unit now phones me and says, I have somebody with a heart attack, the standard of care in 2019 is that they get taken, providing they now have ECG changes consistent with a specific type of heart attack, which is what we call an ST segment elevation heart attack.
That's right.
The standard of care is to take them immediately to the cath lab, which is an angiographic facility. And what we do is we take a picture of the heart artery. So what we do is we can either go through the radial artery into the heart, or we can go through the femoral artery into the heart. We put a catheter, which is like a thin straw, into the opening of the artery, and we inject contrast agent or dye down the artery, and we show a blockage. And then what we do is we take a wire, which is about as thick as a hair. In a previous life, I used to have hair, and we take that wire through the blockage, and then take a balloon over the wire, blow up the balloon, and the balloon is only, let's say, between 2 and 4 millimeters in diameter, sized according to the artery. That stretches the artery open and restores blood flow.
That's right.
And then we generally put a stent into that artery, which is basically a little bit like a scaffolding or spring that you get inside of your pen, and that's made of stainless steel, and that scaffolds the artery open, and that now very effectively and promptly restores blood flow and reduces mortality significantly. So if we look at mortality of people who got to hospital in the mid-1980s, before we had clot-busting agents and before we had stenting, the mortality for heart attack then was in the range of about 15%. Currently, somebody that gets to hospital with a heart attack, the mortality should be less than about 2%. So we've dramatically reduced that mortality, and we obviously want to deal with that heart attack as quickly as possible because effectively time is muscle. The quicker you get the artery open, the more muscle you save, and the lower the chances that that patient will either die or get heart failure or get very nasty arrhythmias. So their quality of life becomes better. Early treatment reduces death, improves quality of life.
Yeah, so it's all about establishing blood flow.
Correct.
We were talking about the plaques before, and then they clog up the artery. There's no blood flow. The heart is saying, oh, I'm dying, I'm not getting any oxygen. So we just want the plaque removed. So that's the whole point, isn't it?
Ischemic heart disease reduces blood flow. We want to improve blood flow.
That's what heart attack is to the general public. That's okay, that's good. Right, so there are some scenarios whereby maybe the stenting, it may not be an option. Let's say you got so many blockages in the heart. And where do you consider surgery?
Okay, so generally the patient who comes in with a heart attack, they get taken emergently to the cath lab, and most of the anatomic subsets there can get dealt with in the cath lab.
Right.
The patient who presents with an unstable cardiac syndrome, let's call it unstable angina, which is chest pain, which is getting increasingly frequent or increasingly severe or lasting longer, we put them on certain medications in order to reduce the oxygen demand of the heart. We do an angiogram and we see that the heart anatomy shows certain narrowings in certain locations.
Right.
Now, certain anatomies are best dealt with surgery. And that has to do with the amount of heart muscle that's in jeopardy, in other words, the amount of muscle that's at risk of dying. It has to do with the amount of calcification that may be in the vessel of the artery. And it has to do with whether the person is diabetic or not, and the number of stents that would require. And we have a thing in cardiology that's been developed in the last 15 odd years, which we call the syntax score. And the syntax score totals up the complexity of the lesions and the presence of calcification and the presence of diabetes. And the higher the syntax score, the better the patient will do with surgery as opposed to a ballooning and stenting strategy. So surgery is a very good option, but coronary artery bypass surgery is much less frequent than it used to be, because as the engineers have helped the cardiologists sort out problems, we've been able to do more and more complex stuff in the cath lab. But certainly surgery is still an option, and depending on the expertise of the unit or the individual cardiologist, perhaps 20% of people with critical disease will be treated with surgery and 80% with stenting. the numbers will vary according to the patient population as well.
That's very good.
Yeah.
That's very good. So the bottom line is risk factors. You go to, if you got blood pressure elevation or high blood pressure, you got diabetes, you're a smoker, your weight is a big issue, cholesterol, all those things, they need to be checked.
They need to be checked.
Therefore, it becomes imperative that we see a physician at least once a year. Everybody that breathes, they say, should see a doctor once a year. Just for a general checkup, isn't it? That would make sense.
Yeah.
Because you will never know that you got blood pressure problems.
Correct.
It's a silent disease.
Correct.
You never know you got cholesterol unless somebody checks it.
Correct.
So we do encourage any age group or any particular age group to say, you get checked or...
Well, certainly the younger you are, the less likely you are to have risk factors.
Right.
But if you have a family history,
Yeah.
there's no point in waiting until you're 50 before you see your doctor. So, because you could easily be dead by the time before you're 50.
That's right.
So certainly when you're in your 20s, you should at least, at that stage of your life, know what your cholesterol is, know what your sugar is, know what your blood pressure is.
Yeah.
So if you had a cardiovascular screening program every 5 years or so in your 20s, that would be fine.
Right.
Once you got into your 30s, if you do have risk factors, then you would want to be screened every couple of years.
Yes.
And certainly once you're in your 40s, you would want to be screened at least annually. But if you have risk factors, then the more frequently you get screened and assessed, the better you're going to do.
That's right.
But patients also need to not only be aware of the risk factors, but they need to be aware of the symptoms that can be associated with the disease process. And obviously everybody is relatively aware of the concept of chest discomfort, which on occasion we will call angina, which is, angina just means pain, and angina pectoris means pain in the chest. So, and we shorten that to angina because we're not very smart, so we just call it angina. But you don't have to present with chest pain. So somebody who's been relatively active and suddenly finds that when they try and, let's say, walk up a hill, gets very out of breath and gets very nauseated or very clammy for no obvious reason, and they have diabetes and a little bit of cholesterol perhaps, they should be seeing their doctor sooner rather than later, because not everybody with heart artery disease will actually present with chest discomfort. They can present, for example, with throat or jaw discomfort, or pain in the shoulders or inside the arms, or even tummy pain on exertion, or they can simply present with reduced exercise tolerance or clamminess or nausea with exertion. So any change in your symptoms is an indication to be seen by your doctor.
So you listen to your body.
The disease.
Listen to your body. Listen to your body. Know yourself.
Yeah.
That's good. That's good. Talking about exercise, you are a classic example. You live by what you say, isn't it? You're a triathlon. Yeah, you do all sorts of things. You like biking. You bike more than you drive.
Correct.
No, it has been a pleasure having you on the show, and we appreciate your coming. We appreciate what you're doing to the community, and thank you so much for coming. We appreciate that. We may drag you back for another topic, and there's so many topics. This is only one part of the heart of the heart, isn't it?
Correct.
There's so many other conditions of the heart. We may drag you back. You never know in 12 months' time. No, we appreciate it. Thank you so much for coming. Now, for our viewers, this is the story today. We're just talking about ischemic heart disease, and we concentrated more on the risk factors, which we highlighted clearly. Dr. Lattouf just highlighted everything clearly. I think it's imperative that you get seen by your GP or family physician for regular checkups. If you know your family history, there's heart disease in the family, you need to be checked out more regularly. And explain this to your doctor. They need to know all that social history. So it's very important. So I guess we've learned something today, and thank you so much for coming, joining us on the show, the Doc Dave Show. We'll join you again next time when we bring yet another interesting topic. God bless. Keep well.